I see two panelists coming in with normal attendee link. I promoted them to panelists.
Okay.
Hey, Susan, we'll let this slide run to the end and then flip to the other deck, okay?
Okay.
I don't want to cut it short in case people are just joining and want to see the updates. Plus, I love the beach scenes.
They're very relaxing, aren't they?
They are. They are.
Okay. Yeah.
And we go from the beach back to reality.
Yes.
The workplace.
Show. Okay. Think. There we go. How's that?
Looks good. Thank you.
You're welcome.
So thank you everyone for joining today. Today is May 3rd and we haven't had a staff meeting in a couple months, so we wanted to take time to get together and kind of share some news and updates and have a bit of a conversation with everyone. Thank you for taking time out of the day to meet with us, and you can go to the next slide. So I'm sure you all saw we have a fun-filled agenda to go over, and I kick it off with the changes that have taken place. As some of you may be aware, our billing coverage analysis and billing charge review have shifted away from department-specific management of these tasks into centralized management. And so as of April 11th, our billing coverage analysis is now being conducted by the Office of Clinical Trials, and Andrea Eyring is the manager leading that effort. And they have 4 dedicated coverage analysts who are reviewing and completing our BCAs for us. And they're, after the draft of the BCA, they're reaching out to the principal investigators to get the PIs to verify the designations are appropriate and in line with standard of care. So that's happening, and then we're being informed after the fact that the BCA is available. Likewise, billing charge review is now being done by our medical center partners. So we had worked with Walker McSwain and Smitha Katragada. I think that's how you pronounce her last name. She is the leader, I believe, the leader of the billing charge review team at the medical center. So they're that transition away from the use of our resources to their resources for charge review has been complete, although a little bumpy. And I know as they gear up and staff up their charge review team, they're still relying pretty heavily on Teresa Nuttall and Pavita to provide some supplemental documentation if they cannot find legacy BCA designations for verification of charge, the dropping of charges. So thank you to our internal team for being patient during these transitions. I know these kind of changes are never easy, but certainly are a worthwhile endeavor to ensure that we're compliant in all that we do and making the designation and processing charges associated with clinical trials. And one point I will make that I've had some discussion with the faculty about as well is this concept of how we do a coverage analysis. So to be equitable across protocol types, sponsor types, the BCA should be conducted in what we call a budget neutral fashion. And that means regardless of what proposed budget the sponsor gives us, we use the NCCN, LCD, and NCD guidelines to justify the billing designations that we're assigning at the time of activation of a trial. So in that way, we're not allowing a proposed budget to influence our decision and bill something to the sponsor that would otherwise have been billable to insurance. And I know people are like, well, wait a minute, that means we're billing insurance for more. Well, in some cases it might mean that, but the point is in applying this principle of budget neutral coverage analysis across the board, then no study is treated any differently than any other study. And no department on campus is treated any differently than other departments on campus. So just because, you know, we have a study that's coming up with an industry partner who has deep pockets and are willing to pay for all of the procedures, when we line that study up against a federally funded study or national cooperative group study where there are no funding opportunities available for procedures, there's an imbalance in a patient's it could be perceived as coercing or enticing a patient to participate in one type of research over another because of the financial ramifications associated with participation in the trial. So, you know, in that way, the patients are being treated equitably across the board if we use those designations, the justifications, to determine how services should be billed. And so that's a point I just wanted to kind of take the time at this meeting to kind of make sure people understood when we say budget neutral BCA, what do we mean? It means that we're ensuring equity across the protocols being opened by our office and across the departments doing clinical research at UNC. And now I'm going to hand it over to Carrie, who's going to touch upon some staffing updates. Next slide, please.
Thanks, Tess. Can you see my video? It's weird. I don't see my video on my screen, but y'all can see my face. Yeah. Okay, good. All right. So that said, I will introduce myself again in case there are new folks in the audience. Okay, good. Kat can see whoever is talking. It's Carrie Lee here. So I'm a thoracic oncologist and the medical director of our office. And before we dive into these numbers, I just want to take a moment to say, speaking of whether or not we can see each other's faces, Some of you I haven't seen in person in a while, and I want to say thank you. I said at another meeting recently that clinical research is really hard. And boy, couldn't that be truer, especially given the circumstances and the additional challenges that we faced this year. Each of you plays a really important role. We're all pieces of the puzzle, whether or not you are, negotiating a contract, onboarding a new staff member, coordinating a patient, consenting a patient, entering data, building a form, writing a protocol, submitting to the IRB, whatever it is that you do, we couldn't do this work without you. So in lieu of me being able to see you in the bioinformatics meeting and personally thank you myself, I just want to say thank you in this format. Because what I'm, there's stuff that's hard about clinical research all the time, but what's making it even harder is that we are notably short-staffed. And I will say this, that it is not unique to UNC. We have been a part of communications with other centers across the country, large academic centers actually who are reaching out to us saying, what are you doing to recruit staff? Where are you finding them? Because we ourselves, the other centers are experiencing a quote unprecedented staffing shortage. And so we're not alone in being short-staffed. This is the thought that this is an effect of COVID, and I'll talk about this in some subsequent slides, but the numbers don't lie. So these are staffing shortages that exist across the CPO, and that also affect our colleagues in OCTR and the staff who live outside of the CPO in the clinical realm and the CAR-T world as well. Our clinical staffing numbers now indicate, and this may be a little bit different day by day or week by week, I probably should say, but we've got about a 43% vacancy across the clinical world and a 30% vacancy rate across the regulatory group. Don't have actually the finance and data or other folks that support the clinical trial work on the side. I think this was just more for simplicity and for you to get a sense of the fact that you're not imagining that you don't have a seat filled next. There's a lot of open positions in the house right now. Next slide, please. Yeah, and so because of this staffing shortage, there's a lot of things that people are feeling. Folks are frustrated. I know there's many of you who are frustrated by having to take on additional workload and losing friends and colleagues. Our investigators, some share that more freely than others. Some of them are frustrated as well. And this has led to burnout, really at every level. I mean, there's burnout going on at the leadership level, as well as the boots on the ground and sort of everything in between. It's really hard what we're being asked to do, the weight that we're being asked to carry in the current circumstances. Some pods have had to take on accrual holds, sort of leads to increased frustration, but these are being done very thoughtfully in order to preserve folks. And not overwhelm the system even further. As a center, we always prioritize which trials we're going to open and which patients we're going to put on trials. We don't say yes to everything. You all know this, but we have been doing what I'll call extreme prioritization lately in some disease groups more than others, really making tough choices about the trials that make it into the pipeline. And the patients that we put on study, and that can be really heart-wrenching or gut-wrenching sometimes when we feel like we could potentially offer something to a patient, in the best of circumstances, but we're in a position now that may break the system even further to offer a trial to a patient. So in some cases, we've referred patients to other institutions or whatnot to do the best we can by way of those patients. But all of these things affect us, in the current environment. Next slide. And so, we've given a lot of thought to how did we get here? And if you've been doing this sort of work for a long time, or even if you haven't, clinical research staffing has always been fragile. This has always been a relatively high turnover industry. There are some really good reasons why people come and go. One that we're really proud of is that many folks spend time in clinical research, and the CPO in particular, and OCTR, as a stepping stone to going on to medical school or nursing school or APP school or whatever. So that's really good, and we're glad that we can support that. But there are other reasons for turnover too, which kind of leads me to some of the bulleted points lower on the slide. And in particular, that this is a really high stress environment. I'm not just making it up, that the workload can be extensive and expectations are high, and that it's a sick patient population. These are reasons for turnover that have come by way of like large surveys that have been taken by ACRP and other professional organizations. So that leads to turnover as well. It's a tough job, and the money associated with it is less competitive lower or less competitive than some other jobs that you can do in clinical research, particularly in the pharma and CRO worlds. So we lose folks for those reasons oftentimes as well. Those of us that are attracted to a job like this, I think it goes without saying, are attracted because of the mission, in large part, over the salary and the opportunity to make really meaningful change in the lives of individuals. So that goes only so far. That keeps people for a while, and some people forever. But the reality of it is that we've got bills to pay, and children to school, and all sorts of other responsibilities that sometimes draw people away. And this is a tough area in the heart of RTP. There's other academic centers and CROs in particular in RTP, some pharma, but there's a lot of competition for a relatively small pool of talent. And prior to COVID, we still rely on our contracting agencies to help us identify talent. But prior to COVID, that pool, those number of applicants that were coming in, the water was deeper in the pool. And post-COVID, we're seeing that there's less applicants being identified, and the people who are identified don't oftentimes have the qualifications that are required for the jobs. And that's, again, not something unique to UNC, but something that's being observed across the country. So for all of those reasons, and I'm sure many others, it's been challenging to find people to staff the office. Next slide. Right, and so this was exacerbated by COVID. We lost a fair number of staff because of all of the additional obligations, whether they be childcare or other family obligations that COVID brought. And that turnover begets turnover, because those of us who are left behind take on the workload of the people who left, and that increases the stress and expectations and drives people to leave themselves sometimes. We were particularly stressed by the UNC School of Medicine hiring freeze. This was done with the intent of preserving all of the people and paying them who remained on, so that there were no layoffs. But it was hard to not be able to post vacancies or new positions until very recently. So we were fragile, then got behind the 8 ball even further with the hiring freeze that we endured. And now on the other side of it, I was explaining the talent pool being less than pre-COVID. Oh, that's the last bullet. Yeah. Unexpected post-COVID, I sort of say in quotes, hopefully thinking post-COVID, the talent pool is smaller and less experienced. So this is all exacerbating an already fragile state. Next slide. And so there's been a ton of brainstorming going on at the leadership level. I'll talk through some of the short-term strategies to bridge us to a better state. And then maybe we can do some brainstorming ourselves either here or as part of messaging to me outside of this meeting. But the short-term fix is there's been some cross coverage that's been requested of people to cover pods that have the most immediate needs. I know cross coverage is not fun. It puts you in an uncomfortable position sometimes when you don't have familiarity with the disease state or the people. But that's been requested of some folks as a short-term Band-Aid. So thank you for being willing to cross-cover your colleagues. Attracting new talent is really critical, right? And so one thing that leaves a lot of room for improvement is our website. And it's a pretty low-hanging fruit too. Our current CPO website, I don't think reflects really who we are and what we do and how mission driven those of us are here are. And so there's an effort to update the website to really make it clear what this job is all about, and to also engage some of you in short video clips, kind of a join the team theme to talk about why your work is important, so that others who are considering the job may actually hear from a real face what it's like to work there. Also updating the website in a way that directly links it to the job postings, so that people don't have to navigate too far from there to figure out how to apply. We're also looking to do more advertisement within UNC. We have a wealth of personnel, I guess I should say, at our fingertips, potentially by way of the UNC graduate schools, perhaps even undergraduate schools for some positions, that we're going to try much more diligently to tap into by way of advertising at virtual career fairs. And some folks even have access to specific groups like PhD groups or research-oriented groups on campus that we can directly market to in a much more strategic and meaningful way. We are working with 5 staffing agencies and have always brought in folks as temps by that way, and then hired them on to contract depending on whether it was a good fit. But there's a thought to explore using our staffing agencies kind of in the more traditional sort of headhunting sense, using them to find people for direct permanent hires. That hasn't been done yet, but that may be done in the future. And our Cancer Center leadership is willing to put money behind this too. So often when you bring somebody in that way, you have to pay the agency that found them, not the person, but the agency that found them, a certain proportion of their salary as a finder's fee. So I'll say that in association with this statement, but in general, that our Cancer Center leadership wants to put money into finding new talent as well. So we're attracting people with mission, but we also, perceive this to be of such great need that putting some money behind it is on the table as well. And then the last point that I'll make here is just that because we have a restricted number of staff right now, or constricted number of staff, we have to make sure that we are really directing effort to the things that are a high return on investment. And so there's been an effort to terminate studies that are just lingering, studies that have completed enrollment, have no patients left, on study or in follow-up, databases locked, sponsor okay with it, that sort of thing, that have been identified, 66 of them since January, and terminated, because these things, they're on people's plates, unless they're off people's plates, particularly with regards to finance and regulatory. So closing out these trials frees up bandwidth to focus on new things. Next slide. Right. So those were some of the short-term strategies. And as I mentioned, a lot of thought being put into this to creatively find new avenues to attract people to the work that we do. But I'm also very interested in what you all think. And maybe there's things that attracted you to work at UNC Lineberger that we're not capitalizing on that could be meaningful to attract new people. So I would like to ask Tess, how much time do we have? It's 1:23 and we have how many more things on the agenda?
Let's see, goals and encore, diversity, equity, inclusion, and admin updates.
Yeah, we've got a lot. So I probably can't have a big conversation with y'all now, but I just want you to know that you can and you should feel empowered to email message me or Tess with any thoughts that you might have on how we can attract talent. Please do that. Your opinion matters, and we want to hear it. Next, is that my last slide?
Yep, that's it for you.
Last slide. Okay, so on that note, I'll end. And thank you again for your patience and your dedication and all that you're doing to keep clinical research afloat during this challenging time.
Thank you, Carrie. Yeah, and just to reiterate, the blank slide is not representative of the ideas being circulated around long-term strategies and solutions to our staffing woes. I think because they're longer term and much less refined and pinned down, we were reluctant to put things on here that are being discussed with Dr. Earp and our leadership team, because we don't want to overpromise or make a statement that in fact gets, evolves over time before it's actually implemented. So there are lots of strategies being considered, but to echo what Dr. Lee said, what Carrie said, we welcome your thoughts, your input on what you perceive to be a strategy we should consider. I guess the point is nothing is off the table at this point. It will take a village, and that's a slide that we'll talk about here in a minute too. So you can move to the next slide, and we're going to spend a few minutes just updating the team about our clinical protocol office goals for 2021. So myself and Dr. Lee and our leadership have met several times to talk about what goals and targets we want to be aiming toward in this year, and certainly recognize that it's my kind of first year at the helm of being the director for the clinical protocol office. So we took a little bit of a serendipitous or circuitous path to reach our goals. It took a bit, but I think we've reached a place where we're happy to share at a high level the content that we're going to be focusing on as we as a leadership team march forward through 2021. Our overall goal domains that we're focusing on include cost, quality, and time. And as we think of cost, we're always thinking about being fiscally responsible for our resources, the tax dollars that we're spending to support our office. We want to be mindful of the fact that these are not a guaranteed revenue stream, but want to use them very carefully and cautiously. When we think about quality, we think about the structure and processes in place to ensure that we have a quality product we're producing for our sponsors. And so we'll focus in on structure and processes this year. And when we think of time, it's the focus is on efficiency and making sure that we're getting the most bang for our buck and most effectively using every resource available to us. And you have to have lofty goals to get lofty achievements in life. So we're going to aim, and we'll go to the next slide. So we talked about some office-wide initiatives, and each of these initiatives have members of the leadership team across functional domains present to work through what a SMART goal within each of these initiatives will look like. But as many of you are aware, a big focus so far in 2021 has been the inclusion of the radiation oncology clinical research portfolio into our office. Most impacted has been our regulatory team because they're assuming responsibility for the entire the portfolio of all of radiation oncology trials. Also, our clinical teams in the CPO have absorbed probably about 2/3, or in the process of absorbing 2/3 of the radiation oncology protocols into their portfolios for management. And so, as you can imagine, there have been countless hours spent to date to get us to where we are, which is in a state of transition. And so we have many more hours to go to feel comfortable and confident in the path of marching forward to have these trials in our portfolio in a a structured way and a way we feel comfortable and confident with. Also, another office-wide initiative is the expansion into partnering with RECs and opening studies jointly. There has been at least a year's worth of work led in large part by Stephanie Ladd to get us to where we are, which is, I think by next month, we'll have 5 or so trials kind of jointly open. That's the aim, that's the goal. Again, we're not quite there. I think we've got a couple that are stuck with some contract negotiations and several cooperative group trials that seem to be on target to open jointly by June. Our regulatory team expansion, we have, as I mentioned, incorporated a large volume of research trials into the regulatory team to support radiation oncology research. And so with that comes the addition of new resources for the regulatory team, additional reg associates and reg assistants to support that volume of work. And these are positions that are posted and actively being pursued. And then accrual, we always pay attention to how close we're coming to our target for the year. And I do know that we have, we'll talk about Encore in a minute, but we do have a new way of displaying our accrual information that's unique. It's called Insights. It's a new platform that Encore offers that we're going to be sharing information with this team, but also with our faculty leadership teams using Insights to track accrual and demographics, et cetera. And, clinical trial activation is another office-wide initiative that I think is, we focus on that year over year, and that's critical for us to make sure we're refining processes and structures, as I mentioned earlier, that are slowing us down. We're identifying what the barriers and obstacles are and meaningfully impacting those in a way that streamline and speed up our clinical trial activation. Next slide, please. So another CPO goal that we're focusing on is the efficient use of electronic systems. And these systems are systems used to maximize our efficiency in how we open and conduct clinical trials. I briefly alluded to Encore. Encore is being expanded. Thankfully, we just went live over the weekend in our new AMI environment. So we're live in Advara managed infrastructure, which Mary will talk about. But now that that's taken place, there's a push to march forward to the expansion of Encore for the entire university, not just Lineberger. And so as Encore goes enterprise-wide, we will be benefiting from some optimizations or enhancements in our use of the product as well. So that's a pretty big objective for us, is to more efficiently and effectively use the tools that are available to us in Encore. And Aaron Crecilius has done a fantastic job with Advara EDC. That's another system that we're going to be focusing on. There's some discussion again of advancing that product to be an enterprise-wide product as well. So we need to work through that with our university to make sure that it doesn't slow us down or impact Lineberger's use of EDC in a way that is just not tenable. So another discussion is Florence optimization. This is we've all kind of tasted the Florence Kool-Aid a little bit, if you will, and I'm hearing very good things from the faculty that have used it, that they really find it intuitive and in collecting signatures and processing essential documents for research. So how can we optimize it? How can we make sure that other groups that should have access to it to be able to use it are doing so in a controlled, and what kind of resourcing will we need to sustain the use of Florence long term? One electronic system I'm kind of intimately involved with is the Shared Investigator Platform, which is a external product that has been developed by a company called Cognizant at the request of 7 or so large pharma companies who are trying to kind of migrate away from their own corporate trial master file systems into a shared common trial master file structure that's supported by this Shared Investigator Platform. So unfortunately, the system's clunky and it's not very user-friendly. And so we will be working with Cognizant and Florence to really advance with an API, an interface built between the two systems that allow us to share documents through the SIP console to these sponsors in a seamless way. And that's a pretty big initiative that will take up a fair amount of resources this year. Also, I know Stephanie's been working on Clinical Pipe, which is a product that sits on top of Epic and allows for EMR information to be extracted and shared more easily with the metadata rave and other case report form systems that sponsors are using. So that's something I think that's in place, and they're now get it refined a bit. A tool that Dr. Lee was working with is the Deep 6 recruitment tool. That is something that we had piloted, and I believe we're considering a round pilot with Deep 6 to see if we can extract information out of our EMR system to allow us to more easily and efficiently identify patients for consideration for the trials. And last but not least, Dr. Lee mentioned our website. That's certainly an electronic system that we're going to maximize this year to be able to more efficiently tap into interested parties who might like to work with Lineberger. Next slide. And the last big goal that we're focusing on this year is staffing. As you would imagine, we need staff, adequate numbers of staff to make sure that we can keep up with the research that we've committed to, but also that we can focus on quality and improving quality and efficiency and satisfaction. Not only the quality of our data, the efficiency of our processes, but our personal satisfaction with the job that we do, and our customer satisfaction with the job we provide or the data we provide. So the staffing focus is, we have a workforce development and recruitment strategy, some of which Dr. Lee alluded to. Within our clinical teams, we have our new manager positions that were created, and I think 3 of the 4 positions have been filled with internal candidates, which again bodes well to the fact that we appreciate developing talent from within and look forward to opportunities to promote people into positions of interest to them for their professional growth and development. That's an investment that we're willing to make because we know it pays dividends in keeping people here and engaged. Wendy is working with the School of Medicine. I believe they're going to be sharing some information very soon about a workforce engagement survey coming that we can all participate in and help inform the school about what efforts we might like to see them take to keep us engaged in our positions. We will be working as a leadership team to do a needs assessment within each group to identify training gaps. Clearly, we recognize training is a never-ending, evolving construct that we want to stay on top of and attend to, because when people are trained, people can be most effective and efficient at their jobs. So that's an area of focus for us, as is diversity, equity, and inclusion. And I believe Myra's going to speak in just a couple minutes about that. And lastly, having to do with staffing is our working forward plan. I think last Friday, we all kind of got a glimpse of what our future state might look like, recognizing, of course, that final decisions, we're only in phase 1 of 5, so final decisions have not been made, but already, we recognize that our culture within the CPO will be changing, will have to change to accommodate this new working forward model. And so I look forward to engaging this group about what that culture might look like and how we can, even in spite of being apart, how we can feel together in the work that we do. Next slide, please. So here's it takes a village. Clinical research doesn't happen by an individual or even a few individuals, it's a team. And we, as Dr. Lee mentioned, recognize that every single role is critical and important, and every single role has subject matter expertise in what you're doing to contribute to the clinical research endeavor. So what I'm challenging us all with is to consider what can you contribute to expand our structure and process as a clinical protocol office. What work instruction can you write? What SOP can you contribute to? It's going to take all of us to really kind of help refine and define our processes, get things in writing that we do. That will help onboard new staff and give them, marching orders, instructions to follow to acclimate to their positions. And in some ways lighten the training load a little bit on each of us, but it will take all of us kind of as an expert in our area, creating that work instruction, creating that step-by-step guide to get people onboarded and to give ourselves the structure we need to be consistent in how we do what we do. So I look forward to your ideas shaping our collective future. Next slide, and I think with that, I'm going to hand it over to Mary to give us an update on Encore.
Hello, everyone. I'm Mary Dwyer, Assistant Director for Clinical Data Operations, and I'm glad to see everybody today. So we went live this morning, or actually over the weekend, with our new version of Encore, and we have moved from servers located here on campus to our hardware being cloud-based and hosted by Advara, the vendor of Encore. So by 11:30 this morning, we'd had 143 sign-ins. We've gotten 0 emails in our support inbox about people having trouble signing in. So, but see if you can break that for us. Go in and see if you have any trouble if you haven't logged in yet today. In terms of the training materials, if you didn't have an opportunity to attend the training sessions with Kendra, you can find them in Sakai. Click on the Encore button to the left-hand side and then scroll all the way down to the bottom for her training materials. So Lineberger Clinical Data Operations, along with new UNC Encore Enterprise staff, have been working on the upgrade and move since early this year. And I'm really so grateful for our team and everyone that contributed. And I know that several of you outside of our group were also called in with some questions over this time. So thanks to everybody who supported this. It was a really good project for everybody to work on together. I'm really proud of our accomplishment. The next step is reconfiguring Encore from a cancer center environment into a research center environment or enterprise environment. And so we'll be working on that along with the optimization that Tess just mentioned. So optimization means that we will look at some features in Encore that we think we could be using better than we are. And we'll talk to subject matter experts within those of you that are using the features currently to see what is your workflow and how does that compare with what we could be doing in the system. And from that, we'll come out with some training and some improvements that should help us capitalize on our investment in Encore and also improve our efficiencies. The enterprise go live is expected at the end of the summer. So that's, that's really all I had to say today. So thanks for listening. Next slide.
Thanks, Mary. Yep, I think, having the workflow workshops, and I know there a number attending this call have sat in on some of the enterprise-wide workflow workshops to experience kind of the foundational information that other users on campus are being given about the functionality of Encore. And it's not because we're asking you to sit in because you don't have that experience. We Lineberger certainly are the experts at using Encore, but just so that you can understand from a very basic level how other centers, how other departments are being instructed in the use of Encore, and perhaps even learn a few new things that you didn't realize were features in Encore. Because we, the Cancer Center, maybe have never really utilized them or maximized the use of certain features, as Mary said. So thank you for sitting in and recognizing too that in those workflow workshops, we're starting to kind of understand, you hear conversations happening across departments on campus about how others might like to use Encore. One point to mention before we move on to diversity, equity, inclusion about Lineberger's use of Encore. just to reiterate, or if it's not been stated clearly, we will exist in our own organizational unit. So Lineberger will exist as an organizational unit in Encore, separate and distinct from every other organizational unit in Encore. So there is a firewall, if you will, between what we do at Lineberger and what we can access and what everybody else on campus can access. And most of the features of how we use Encore will be separate and distinct from other groups. So there are some common things that decisions that have to be made that will impact both organizational units, but the vast majority of what we do, other than enhancements, will not be changing in how we use Encore. And with that, I'll let Myra Suarez speak to our diversity, equity, and inclusion progress.
Okay. Hi, everyone. I'm Myra. I'm a regulatory associate with GU and Lung, for those of you who don't know me. And as most of you know, the leadership had established a DEI committee a few months back. And so in those meetings, we took some feedback from the survey that was sent out at the end of the year and realized that we needed to put out a call for some additional volunteers to ensure that the committee was more representative and inclusive of our staff. And so with that, we have 6 new members that will be joining the newly formed committee. That'll be joining myself and Pavita, who was on the previous committee. So we have Michael Rojas, Nidhi Jane, Caroline Dinkins, Jane Mejia, Chloe Moore, and Juliana Macaron. So welcome to all of those members. We actually had our first meeting last week, and I think it was a very productive first meeting. So we've started brainstorming and looking at some of the previous survey results and ideas from within the group on how we can proceed and things that we need to look at immediately, and work with leadership to establish an action plan and implementing some items to improve diversity and equity and inclusion at the CPO.
Thanks, Myra. I'm glad to hear the first meeting went well, and certainly look forward to your report out back to us to see how we can help.
Okay, thank you.
Yep, next slide, please. Now I'm going to hand it over to Leslie. Leslie Schreiner is going to give us a few administrative updates as there have been some changes in this domain since our last meeting. You're on mute.
And I said, shoot, in case you were trying to read my lips there. Hello, everybody. We are very lucky that Stephanie Belanger and I have been working with, and others with the Cancer Hospital, and we have been allocated some additional space. And this is really important for our clinical staff who have had limited space over the past year and have done a lot of walking back and forth between Lineberger and the Cancer Hospital. So that came online officially today. We have 5 desks that can be used, and I sent out an email and calendar invites to all the clinical staff. So if you did not receive that on Friday afternoon, please email me so that I can make sure that you receive that. And it's starting out a little primitive. You can think about camping when you're going there. It's just the desk right now. So you're wireless and you have a spot to lock items up at, but that is the extent of what we have, but it's a good space to go and work from while we're getting the equipment all installed over the next couple of weeks. That's really what I have to say about space at this point. Except for reminders, when you are coming on campus, make sure that you do the health check and that you log into one of the calendars to sign up for your space to make sure that you have a place to sit when you come on campus, whether if you're clinical, administrative, or regulatory as well. And then the other item that I wanted to just touch base on with everyone today is a new position within the admin support group. And it's the title for it is Clinical Research Assistant. And this is someone who has the position has come out of a real need that we saw over the past year in how do we organize ourselves and get all of our belongings, such as shippers, kits, binders, from one place to another. And this role is going to be essential, helping us out with getting some organization as we're working forward into however our work will be in the future. Thanks to everybody. Good to hopefully see some people soon.
Thank you, Leslie. Yeah, I know it's been interesting to acclimate to a new job remotely, but and people have made me particularly very welcome, but I certainly am looking forward to spending some time on campus. And I think that was the end of the slide deck. If you just want to advance, Susan, to make sure. Yep. Okay. So I don't know if anybody has any questions that you would like for one of us to address, feel free to put something in the chat. We'll give folks a minute to type.
Yeah, sorry, Tess, I didn't mean to interrupt, but if there are other staffing suggestions that you want to include in the chat now. We also don't want to forget to introduce any new staff. Did we cover that?
Oh, you know what? I forgot to put a slide in to prompt folks.
Okay.
I don't know if we, if they're, I don't think we've made them panelists to be able to speak.
Mm-hmm.
Did we do that? Here, hold on, let me find the email. I can talk through it.
Yeah, good. And I'm seeing some suggestions come into panelists about staffing. So thank you.
Let me see. Sorry, guys. Somebody sent a list last week and I'm struggling to find it now.
Tess, I can email that to you if you want. I already have it. I could just attach it and send it to you.
Sure, that'd be great.
Okay, hold on just a moment. The agenda is coming to you. That's got the listing.
Man, it sounds like people have internet issues down in North Carolina, huh?
Uh-huh.
Oh. So make sure my phone has a hotspot. Is that what I'm hearing when I move? Okay, here we go. Is it on there?
It's an attachment.
The agenda. Oh yeah, here we go.
Yeah.
It is on there. I will read them since we didn't advance people to be panelists. So on the regulatory team, our newest staff members, we have Patricia Brock is a regulatory associate for the melanoma and neuropod. We have Elise Schmidt, who's a regulatory associate for lymphoma. And we have Katie Wheeler, who's a regulatory assistant for leukemia and multiple myeloma. So those are the regulatory folks. And for the clinical operations teams, we have our clinical research managers that were promoted, Blair Adams, Jennifer Grunn, and Almir Omer Spayek. Hopefully I got that right, Omer Spayek. We have Carlos Velez, who has joined as a study coordinator for the breast team, and we have Rosemarie Baston, who has also joined as a study coordinator for the breast team. And we have Jessie Post, who is a study coordinator for leukemia. Welcome to each of you. In the data operations group, we have Vanessa Lynch, who started with Mary's group as a CDMA. And in our post-award team for the Business Office for Finance, Tracy has Laura Moore, who began as a clinical trials AP. Welcome, everybody. And yeah. No, I can't see my chat. Any questions that we need to go back to, Carrie?
Well, thank you. There's like 5 or 6 different people chiming in on the panelist chat about suggestions. And one of them, just sort of broadly speaking, centers around creating an internship to places like UNCW and Durham Tech and others that have clinical research programs. And that is absolutely something that we've discussed, not really site specific exactly, but the concept of having an internship, because we have to figure out how to create an internal pipeline of candidates as opposed to always relying on people to come in externally or to find these external needles in a haystack. So I want to acknowledge that as a really great suggestion, and one that will hopefully come to fruition in one way or another in the coming, months to years. Sometimes it takes a little while to get those things off the ground, but as Tess said earlier, worth the investment.
And Janine had a comment about a Florence administrator to free up bandwidth. That is something, Janine, that Allison and Shaw and I have been talking a little bit about to figure out what kind of new position or new role to support Florence we might consider adding to the reg team in the coming year, because we recognize as the system has grown and we're using it, which is great, it does, even with 3 dedicated super users, they still have full-time jobs as reg assistants. So we are looking at options for a resource to support Florence, either within the CPO or perhaps, with the bioinformatics group, but more than likely we'll be working on something very soon for some relief there.
The other thing I'll say too is you're right. We are, another comment about, we are talking a lot about attracting talent, but equally important to retain the talent that we have. So yeah, brainstorming lots on that front about what we can do given the current restrictions. So thank you for that suggestion, and it's being considered very strongly as well.
And I don't see any other questions.
Yeah. Oh wait, there's do you want to talk about working forward, Tess or Wendy? There's a comment about regarding return to campus. Oh, is the recording online anywhere? Does anybody know if the working forward recording, there was a 20-minute session, I missed it too, I think I was in clinic that day, is that posted anywhere?
Yeah, I think the link it's a YouTube video. So if you just go to the original email about working forward and click on it, it should take you directly to the YouTube video.
Okay, and one of our panelists will send it out after the meeting as well. So good question. Good. All right, looks like we've got bio break time.
Okay, guys. Well, thank you for your time, and I look forward to seeing you again next month.
Yeah, thanks everyone.
Take care.